falciparum. Okay, but you can see the gametocytes. Okay, they do appear in the peripheral blood. All right, so that's for morphological differences. Okay, so as doctors, if you're just doing your general practice, okay, you will not require the knowledge of the details of the morphology lah. But if you're in the laboratory, of course, you have to know. Okay, but it is useful to know the differences, because you'll even as general practitioners, you'll be reading the laboratory report. So it will be useful for you to know what is reported. Okay, otherwise difficult for you to interpret if you don't know what is reported. Okay, so even though as a general practitioner or as a general medical doctor, you don't have to know too much details, still, you know, you need to know a little bit about the morphology of the malaria parasites. Okay, so I suppose you'll be covering some of this in the practicals. Okay, and sometimes popular questions in the OSPE as well. They show you some parasite and ask you to identify the species. So you have to know, okay, the morphology a bit as well. Okay, any other information you want to add on before we move on to the next learning need? Okay, so yeah, anything else on this one?
Earlier, doctor asked for the differences between Aedes and Anopheles.
I'd
like to show. Okay, so everyone can see my slide.
Yep.
Okay, for Aedes, basically for the appearance of it, the adult has black and white patches, while Anopheles will be like yellowish like that. And then looking at this siphon, larva as siphon, it stays angled to the water surface, but Anopheles, it doesn't have a siphon and stays parallel to the water surface. And while Aedes will be aggressive day biter, but Anopheles will be at dawn and dusk during the night, just like what Aiman explained just now. And Aedes is anthrophilic, while Anopheles is zoophilic. I think that's the basic thing that we need to know, I guess. So yeah,
okay.
all from me.
Okay, so can we move on? Or anything else on this, mosquitoes?
Doctor.
Yeah.
I'm actually quite confused about the anthrophilic and zoophilic just now, because like for the Plasmodium malariae, Plasmodium vivax, all that it's from human to human. So
yes.
does that mean that the Anopheles mosquito also can be anthrophilic, and then in some cases it's zoophilic?
There are different species of Anopheles. So some are zoophilic, some are anthrophilic. Okay? I can't remember all the species, but things like Anopheles maculatus and so on. Okay? So there are various species, and in fact, several species can transmit malaria. Okay? While for dengue is only the Aedes aegypti. Okay. Okay, only two I think. Albopictus also, but not that many. But Anopheles, there are quite a number. If I'm not mistaken, up to 5 species which can transmit malaria. So some are zoophilic, some are anthropophilic. Okay. Okay, so can we move on?
Yes.
Okay.
Can I try for the next learning needs?
Yeah, yes.
Okay, reservoir host of malaria parasites. Reservoir host is an animal host in which a parasite commonly live. Certain species of malaria called Plasmodium nosai has been recognized to be a cause of significant numbers of human infections. And Plasmodium nosai is a species that naturally infect macaque monkeys living in Southeast Asia, and this monkey is the reservoir host. Humans living in close proximity to population of these macaque monkeys may be at risk of infection with this zoonotic parasite. Yeah, that's all.
Okay. Right. Anything else? Okay, so the for Plasmodium nosai, the reservoir host is macaque monkeys. Okay, can we move on to next learning need, which is the clinical strength, sign and symptoms and their pathophysiology.
Maybe I'll start first on this. Okay, so as we can see here, the symptoms of malaria can include fever, chills, sweating, dry cough, and muscle pain. So here we can see that in a pregnant woman, the baby could have a low gestation body weight due to the erythrocytic cycle. Maybe they invaded into the placenta, and then the baby could undergo premature birth or stillbirth. Yeah, that's all.
Okay, anybody else want to add? So that's signs and symptoms.
Maybe I'd like to add up on the intermittent fever. It is due to the synchronous lysis of the infected erythrocytes. The fever spike cause may reach up and correspond to the rupture of the red blood cell as merozoites are released from the schizon infected cell. So the chill and rigor and also the headache are caused by the parasites which are multiplying in the erythrocyte. And she also explained about the pale loop, which means like the anemia. It is caused by the destruction of erythrocytes, and there can also be suppression of the red blood cell production in the bone marrow. And hepatomegaly or the splenomegaly, this one is due to the filtering out of excessive destroyed red blood cell after the hemolysis and occurs only during malaria. It will be it's due to the accumulation of the parasitized red blood cell as well as proliferation of white blood cells. I think that's it.
Okay, so those are some of the pathophysiological basis of the signs and symptoms. Okay, so fever is due to synchronous lysis of infected erythrocytes. Anemia due to two mechanisms. Okay, but the main mechanism is destruction of the erythrocyte by the parasite. Okay, as they rupture. The second mechanism, which is not the main one, is somehow this parasite also inhibit red blood cell formation in the marrow. So there's reduced production, but that's not the main one. Okay? for the enlargement of the liver and the spleen, as Nani mentioned just now, okay, is due to increasing workload of the reticuloendothelial cells, mainly the macrophages in the liver and the spleen, okay, trying to ingest the damaged and parasitized red cells. So it's equivalent to overwork, okay. All right, so they get enlarged. Okay, anybody else want to add anything?
I'd like to add on a bit only about the symptoms. For those who are long-term residents in an endemic area, they normally have a partial immunity, so their symptoms will be a bit lesser lah. That's all. Thank you.
Yes. Okay. Anything else? So I think you have to understand that like the one in our trigger, okay, fever, chills, rigor, sweating, okay, these symptoms are not really specific for any species, and also actually not really specific for malaria, as there are some other infections which can give this sort of manifestation. But as I emphasized in the beginning, okay, that when patients tell you if they correctly describe that and if what they describe is correct, is rigors, there are not too many infections which cause rigors, and one of them is malaria. Okay, so you can suspect malaria in somebody with chills and rigors. And why is the fever intermittent? Depending on the synchronous rupture of the infected red cells. If it is not synchronous, there are some patients where the infection is not synchronous, meaning that there are different times that the red cells are infected and therefore they rupture at different times. Then you don't have the definite pattern. Okay, so the definite intermittent pattern, for example, fever every third day, okay, or every 24 hours depending, okay. I think for malaria is every 72 hours, okay. But this one, as I said earlier, it depends on the synchronous rupture of the infected erythrocyte. So if it is not synchronous, then you don't get this pattern. It does not mean that patient who don't have intermittent fever doesn't have malaria. It's just that the infection may not be synchronous. Okay, so again, you have to recognize that when you ask in the history for patient whether they have intermittent fever or not, okay? Because sometimes it may not follow the typical pattern of malaria because of the erythrocytes are infected at different times. Okay,
So,
is that understood? Yeah.
I'd like to ask for some reconfirmation about this. So, the cyclic rupture of the erythrocytes, is it does it have something to do with the life cycle of the plasmodium? It does it?
It does. Okay, it does, because certain the stage may differ. Okay, but what I mean is some of the parasite may infect the red cells a bit later. They circulate in the blood for some time before they infect the red cells. You know what I mean? So it's not every parasite that released into the blood go into the red cell at the same time. Some of them linger around before they go into the red cell, so that can make the thing asynchronous. You get what I mean?
Yeah, I get what you mean. Thank you.
Yeah. All right. Anything else on this? Okay. So if not, then I think we can proceed on to the lab investigation.
Can I start on this one?
Yeah.
Okay. So I'd like to explain about the rapid diagnostic test. So there are two types of rapid diagnostic tests that based on different detections and schemes that are presently available and becoming more frequently used around the world. So the first type is based on the detection of Plasmodium histidine-rich protein 2, which is HRP2. So first, the HRP2 based detection is limited to only Plasmodium falciparum and may yield negative results in cases which Plasmodium falciparum strains either does not express HRP2 antigens. So the second type is rapid diagnostic. The second type of rapid diagnostic test is based on the detection of also on P. falciparum, but this time it's specific to lactase dehydrogenase and pan-plasmodium LDH. So this also, wait. Oh yeah, that's all. Thank you.
Okay.
Okay, I want to say.
Hmm.
Okay, Nani want to say? Okay. Okay, just now Anne has explained about the antigen detection. So I want to give 2 points, which is molecular diagnosis and serology. Okay, first, molecular diagnosis. Parasite nucleic acid are detected using polymerase change reaction, which is PCR. Although this technique may be slightly more sensitive than smear microscopy, it is limited utility for the diagnosis of acutely ill patient in the standard healthcare setting. PCR results are often not available quickly enough to be of value in establishing the diagnosis of malarial infections. So we can say that PCR is most useful for confirming the species of malaria parasite after the diagnosis has been established by either smear microscopy. Okay, for the serology, serology detects antibodies against malaria parasites using either indirect immunofluorescence, which is IFA, or enzyme-linked immunosorbent assay, ELISA. Serology does not detect current infection, but rather measure past exposure. That's all for me.
Okay, good. Anybody else want to add anything else?
I have something to add. Yeah. I'll share my screen. Okay. Yeah. You guys can see my screen.
Yes.
Yes.
Yeah, I have several investigations. The first one is the blood film for malaria parasite. We know that we can use thin or thick blood films, but we can sometimes we cannot clearly differentiate between because all of them clearly have ring form like stages, so we can't clearly diagnose or to say whether this is either Plasmodium falciparum or either Plasmodium knowlesi. So we can use like the PCR to really confirm. So okay, for the second one is full blood count. Okay, full blood count for falciparum, Plasmodium falciparum. Generally our white blood cell would be normal, but it will also lead to anemia because of the rupture of red blood cells. Okay, so the third one will be blood urea and serum electrolytes. So they will usually test for the sodium, the calcium, albumin level. So usually patients with malaria will have sodium, calcium, albumin levels which are very low. So we can use this BUSE to test their levels. So the fourth one is CRP levels, which there we have C-reactive protein raised when they have infection with Plasmodium species. So for this second one is liver profile. So the bilirubin it will often raise because of the Plasmodium which invade their liver. So the liver enzyme will cause the amount elevations of the liver enzyme. So the last one is blood glucose. So the blood glucose will be low in more severe case, for example, the Plasmodium falciparum, which they contains a lot of parasite in the red blood cells. And I have something to add for this the ELISA, the enzyme-linked immunosorbent assays. Okay, the pictures shows the picture that I attached is the figure 6. Okay, this one, the right hand side, this one is the enzyme-linked immunosorbent assays, also known as ELISA. This is the diagram, the picture. So you can have a look at this. And I think that's all for me.
Okay. So for clinical practice, the routine investigation that we do is what has been mentioned by Ko. Okay. So for diagnosis, it is the blood film for malarial parasites which is done. Okay. Very common. Okay. Then the short form is BFMP. Okay. And we normally do it 3 times if it is negative for the first time. Okay. Usually the best time to do it is during the peak of the fever. Okay, but in patient who just come in, you don't want, even if the patient is not having fever, when the patient you are seeing the patient who you suspect is malaria, you still take it. So the first blood film you can take anytime as soon as you suspect malaria. But if that is negative, it is better for you to wait until the patient is febrile so that the yield is higher, the chance of it being positive is higher. Okay. If it's negative for the first time, we normally do it 3 times. Okay. So as you have understood during the trigger introduction, that the thick blood film merely detects the presence of parasites because it doesn't show the morphology of the not the detailed morphology. So you can only see the detailed morphology using the thin blood film. Therefore, thin blood film is for you to recognize the species, try to identify the species. Okay. And the other investigation are done. Okay, for blood count, you want to assess the severity. Patients are usually anemic, so you want to find how much the hemoglobin is. You also want to find out what is the the white cell count. Okay, depending on the species, it may be increased, it may be normal. Okay, usually for platelet count, which is part of the full blood count, usually all types of malaria, the platelet count will be reduced. But in severe malaria, platelet count will be very much reduced, very low. Okay, so that's routinely done. And the other one is what Ko mentioned. The short form is BUSE. We call it BUS. Okay, blood urea serum electrolyte. So this includes your urea. Okay, this is a measure of kidney function. And serum electrolytes, which is your sodium potassium chloride. Okay, and CRP is something which is not specific. Okay, but it can be done to just for monitoring. When the patient recovers, the CRP becomes lower. Okay. Then you want to assess the liver function as well, because you know that it first developed in the liver, the parasite, so there may be some liver damage. Again, later on, the liver may be enlarged due to its involvement in destroying the parasitized erythrocytes. Yeah, blood glucose is routinely done because in severe malaria, you can have what we call hypoglycemia. So you want to detect that in a patient who has malaria and also hypoglycemic, that is an indicator that the patient is having severe malaria. So you have to be cautious because increased chance of the malaria leading to mortality. Okay, so one of the things which must be done is blood glucose. Okay, so that's from the clinical viewpoint when you actually practice. Now, you're talking about molecular studies. Yes, they can be done, especially if you suspect null xi, because that's the only way to confirm it. But as rightly mentioned just now, it doesn't really affect much of the management, because you have to make the diagnosis based on your blood film. You cannot wait for the PCR results for you to treat the patient. And also, it is expensive, so it is not routinely done for government hospital. Okay, and it's not also available in. It is not available. The test is not available in government hospitals, only in the universities. Okay, so that's molecular diagnosis. Serology are not often done because it is not for detecting acute malaria, but for detecting past exposure. I can give you a scenario where it can be used, but a patient comes to you with a mass in the abdomen, okay, and when you examine the patient, you feel the spleen. So you want to work out the cause of the enlarged spleen. So one of the causes will be something called chronic malaria. The patient now is not having fever or anything, just the spleen is enlarged. So you want to find out whether it could be related to past infection by malaria. So you can do a serology. Okay, so it tells you whether there is past infection or not. Okay. The rapid diagnostic test, which was also mentioned earlier, yes, it can be done. Okay, it has been used in certain bigger centers, but it's only for falciparum. Okay, and remember, it can also be negative for falciparum. So it's even though it's useful, okay, but it doesn't detect all the spectrum of the other species. Okay, so that's a summary of the investigation that you do on patients with malaria. And there are other investigation which you need to do depending on the patient presentation. Okay, but I think because that involves further management of malaria if something else develops, so I don't think it's really required for you to know now. But the basic thing is BFMP, FBC, BUSC, okay, LFT, blood glucose. Okay, so the very basic things like that, you should know that those are routinely done. All right. Okay. Anything else?
No.
No. Can we move on?
Yes.
Okay. Very brief treatment and monitoring. We have discussed the drug just now. Okay. So can somebody maybe just summarize?
I want to share. Okay, I want to share my screen first. Okay, this information I get from YouTube Osmosis. So for the treatment, I have 4 points, which is first, the suppressive treatment, or we call as chemoprophylaxis. Chemoprophylaxis. Okay, the suppressive treatment kills sporozoite before they infect hepatocyte, which is before they infect the liver cells, usually given to travelers that are headed to a country with endemic malaria. Next is therapeutic treatment. The therapeutic treatment is aimed to eliminating merozoites in the erythrocytic phase. Erythrocytic phase is the process of proliferation sporozoite in the blood cell. Okay, it's usually given during an active infection. Besides that, medication depends on several factors, which is severity of infection, age of the patients, pregnancy status, local malaria resistant pattern, and Plasmodium species. Okay, last the other two is gametocidal treatment, which is aimed killing the gametocyte, which is gametocyte in the human host, not in the mosquitoes, but in the humans. Prevents spread of disease and creation of resistant forms of the parasites. Lastly, there is radical treatment aimed at killing hypnozoites in the liver from P. vivax and P. ovale infections. So we can see that P. vivax and P. ovale is the domain in the liver stage, which is hypnozoites. Okay, that's all from me.
Okay. Mhm. All right. So in principle, those are all correct. Okay. So just remember that prophylaxis, you are dealing with treating people before they develop the infections. So normally travel advisory, for example, for people who come from non-malaria country like UK, Western countries who wants to travel to malarious area, they are advised to take chemoprophylaxis. Okay, there are certain drugs which are used for this. Okay, then the others will be treating the malaria after the infection develops. Again, the choice of treatment, as was mentioned just now, depends on several things. The severity of the infection, okay, whether the patient is pregnant or not, okay. As I said just now, knowledge of resistance. Okay, so if you know that the patient has traveled to a chloroquine resistant area, and you are treating that sort of malaria, so you want to avoid chloroquine and use other drugs. So that affects the choice of treatment as well as the Plasmodium species. Okay, falciparum, if it is associated with severe infection, or nosai, if it is infected with associated with severe infection, you want to use a more powerful drug like the artemisinin derivatives and so on. Okay, so yes, those are good points. Okay? The choice of treatment depends on several factors. Okay, anybody wants to add?
May I add?
Yeah.
All right. So for the monitoring of treatment, the
Okay.
the levels of parasitemia, which is the quantitative content of the parasites in blood, is monitored just like in the trigger, where they use the blood film test to monitor the level of parasites in the blood daily on a daily basis. It is actually to check whether the antimalarial drugs are working. So yeah, that's all. Thank you.
Yes. Okay. Any more on this, on treatment and monitoring? I was asking you the other day about discharging the patient. Okay, the patient after 4 days treatment, he asked for discharge already. He wants to go home. Doctor, I have to go home. Nobody looking after my wife at home. So what do you tell him?
Maybe we can tell him to quarantine himself.
At home?
Probably yes. I don't know.
Any other suggestion?
Maybe I'll tell him not to go home first, because if he goes home, he might infect his wife. So stay in the hospital first. if you are still infective lah, of course. But if he's not infective anymore, then you can go home lah.
Okay, so how do you determine whether he's infective or not?
Using the test crew said.
Using which test?
The test crew mentioned.
Aha, okay.
All
So
those. Not all lah, like one of them.
Which one of them?
One of the test crew said.
Which one is it cool?
I think it's full blood count because just now the explanation is although the white blood cell count is generally still normal, maybe the patient does not have any fever, but if someone still has the Plasmodium, Vitis Plasmodium species, the neutrophil level in the body will still achieve like more than normal. So I think full blood count will be appropriate. Correct me if
Anybody has different answer? So aku say full blood count.
Maybe like can show him the results, like got a lot of parasite in your body. You can go back home.
Yeah. So actually the answer is the parasite count lah. I mean, you're looking at the BFMP, blood film for malaria parasite. So as far as possible, you would like the BFMP to be negative, meaning that clear of everything before you discharge. Okay, but if the patient really has a genuine reason to come out of the hospital earlier, okay, then you look at one part of the parasite. Okay, you look at the gametocyte, because that is the one which can develop in the mosquito. All right, so if there's no gametocyte at all, but there may be one or two ring forms, if the patient really has an urgent reason to go out, it can be allowed. Okay, but otherwise we try to retain them until they are completely free of the parasite. Okay, is that understood?
Yes, Prof. Thank you.
Yes.
Okay, so any other things on monitoring of the treatment?
Professor. So like for instance, if the person is still infective lah, but he has a very genuine reason of going home, and I know a patient has every right to choose whether or not he wants to be treated or and whatnot. So how is it? Can we like retain him? Tell him like you must stay here. You must. Are doctors allowed to do that?
We have to explain to patient. You have to explain to patient and give the correct information. But if the patient insists on going back, okay, there are certain situations where they can be allowed, but they have to sign what we call it, discharge at on risk. That is one thing. But things like this one, because this comes under the Public Health Infectious Disease Act, so they may be against the law, so they may be caught by police. Like people escaping the COVID thing also, they may be caught by police and brought back to hospital. All right, but there are certain condition. If it is not against the law, then but we are still worried about them, so we ask them to sign discharge at your own risk. Meaning anything happen to you is hospital is not responsible. Okay, but if it is under the Public Health Ordinance Act, then it can be a crime, and therefore they can be arrested by police and brought back to hospital.
Prof, I have a question regarding the treatment. Does the patient need to finish and complete the treatment to avoid drug resistance in the Plasmodium?
No, I mean, if you notice that the parasite count decrease and there's no more parasite after that, it means that the parasites are sensitive. Okay. Yeah.
Okay.
So yeah, you just finish the course of the routine treatment.
Okay.
Doctor, I think I would like to add up one point. Anti-malarial medication may be used in a very specific way for people at particularly high risk for malaria, such as pregnant women and young children. So in these cases, like high-risk individuals receive a dose or series of doses of malaria medication in order to prevent malaria. So it is this form of prevention is called as intermittent preventive therapy. So if let's say like a pregnant woman or a young children have been diagnosed with malaria infection, so they have to be receiving series of doses, right? So if let's say the parent already received one dose and then they want their child to balik also, and then will that be like how to say how to actually explain to them like your children have to receive like series of doses like that?
No, I mean, it depends on whether they are in a malaria risk area or not. Yeah. So if you're not in the malaria risk area, then it's not necessary, right? But
so like the
yeah,
African trees area, this type of people like they should be receiving series of doses, doctor.
yeah. Okay. All right. Anything else? No. Okay. So if not, we move on to complications. We still have a number of other things.
Can I?
Yeah.
Right. The complications of malaria, for example, renal failure, respiratory disease, also hypoglycemia, and circulatory collapse. For malaria infection during pregnancy, we know that malaria during pregnancy is very harmful, not only for the mothers but also to the unborn children. It can contribute to maternal anemia, also the fetal loss. They are at great higher risk of being delivered prematurely or with low birth weight, with consequently decreased chances of survival during the early months of life. Also, the complications of severe malaria, it usually occurs in Plasmodium falciparum and Plasmodium mosaic infections. For example, coma associated with increased intracranial pressure or cerebral malaria, also severe anemia and abnormal spontaneous bleeding, also extreme weakness, jaundice, acute renal failure, also acute respiratory distress syndrome. Yeah, that's all.
Okay. Any more? No. Any more? No? Okay. So just to recap, so there are several complications. Okay. So if there are any manifestation of any of these developing in a patient, they are classified as severe malaria. Okay. So if not, then they are the non-severe type of malaria. So remember renal failure, hypoglycemia, okay, adult respiratory distress syndrome, cerebral malaria, okay, metabolic acidosis, severe anemia. These are complications of malaria. Okay. All right, any question? Okay, and the species which tends to be associated was mentioned just now. Okay, very often is Falciparum. Okay, and we said just now. Okay, it's probably partly due to the fact that a lot of the mature schizoid tend to stick to the inner lining of the internal blood vessels, okay, causing this problem. Okay, but it also occurs in Nolzai. Okay, although the pathophysiology is the mechanism is not complicated, okay, because they tends to behave slightly different than falciparum. Okay, have you heard the term black water fever? No. Okay.
No, doctor.
So it's also a severe malaria, which is associated with renal failure. Black water fever is because the patient has fever, and when they pass urine, the urine is so dark, okay, dark red. Okay, so they just call it black water fever. Okay, this due to actually release of the products from the breakdown of the red cells, okay, leading to excretion of hemoglobin in the urine. Okay, and this hemoglobin is toxic to the renal epithelial cells, giving rise to renal failure. So black water fever is that condition where patient has hemoglobin in the urine, causing it to be very dark red in color, and they also have renal failure due to the toxic effect of the hemoglobin. Okay. Can we move on?
Yes.
Right. Behavioral strength.
Anyone wants to add idea on risk factor? Or okay, I will start first if no one wants to give idea. Okay. All right. The risk factor. What the first one is age. Can everyone hear me?
Yes.
Yeah.
Oh, okay. Okay, the first one is age. Young children are more likely to get malaria from 5 to 15 years old. This is due to the weak immune system that will double the risk of getting malaria. Also, pregnancy, it will increase risk of getting malaria due to also lower immune system. They are more likely to develop the illness. Also, will affect the newborn babies from the transmission from the mother. Next is blood transfusions that spread from one person to another via the blood transfusions. Also, travelers or migrant, they're visiting a region with high rate of malaria, especially for those that coming from areas with little or no malaria transmission, so there are lack of immunity. Other than that, those that living in a region with high rate of malaria, for example, rural areas, poor rural population in in malaria endemic areas often cannot afford the housing and bed nets that will protect them from exposure to mosquitoes, and most of them are lack of knowledge to recognize malaria and to treat it correctly. Usually, they only use a traditional method, which is ineffective for malaria disease. And lastly, the risk factor is for those who are working in the jungle, such as rubber tappers. Yeah, that's all.
Okay, good. Anything else? Anybody wants to add any more?
I want to add on for the risk factor. I think deforestation is linked with malaria. Because deforestation will increase the temperatures, which promoting more ideal breeding site for the mosquitoes. And it will also more likely to pull less acidic water, which is the preference to the Anopheles larvae development. Also, it will reduce the absorption of water, and this will create breeding grounds for the Anopheles mosquitoes. That's all.
Okay. Any more? Anybody wants to add?
May I add another factor?
Yeah.
Another factor that can affect this malaria is that genetic factors. So there are some studies shown that the sex-linked gene for the glucose 6-phosphate dehydrogenase, the G6PD, has helped to increase resistance against malaria. And that's all from me. Thank you.
Okay. Mm-hmm.
I'd like to add on the genetics part. So besides G6PD, like what Justine said just now, sickle cell traits, thalassemia, Southeast Asian ovalocytosis, which is a hereditary elliptocytosis, also known as ovalocytosis, which is an inherited blood disorder which has abnormally large number of a person's red blood cells that are elliptical rather than biconcave shape. So basically, it's very small and different size red blood cells are, and also absence of Duffy factor, glycophorin A. So all of these serves as a protective measure which increases the survival advantage of the person. That's all. Thank you.
Yeah. Okay. So I think yeah, these are genetic factors, but as Annabelle mentioned, it actually developed due to evolution in patients who live in the malarial areas to make them sort of protected against the malaria. So I think you have learned from the earlier trigger that we had in block 1, that thalassemia, patients with thalassemia. Actually, thalassemia itself, a severe condition is not, but thalassemia trait, the red cells are a bit resistant to malaria infection. And the same thing for sickle cell trait, but the sickle cell disease, not that they are susceptible, but sickle cell trait, they are resistant. Yeah, so what you mentioned is all correct. G6PD deficiency, SEAO, okay, all are protective factors. Not to say that they are completely resistant and don't develop malaria. They do, but there is relative resistance. Okay, so yeah, what you mentioned is correct. Right, any more? Okay, let's move on if there's no more on risk factors. So the implications, psychosocial.
Anyone want to give any idea on the next learning needs?
Okay, then I'll talk about the psychosocial implication of malaria. Some of the patients will suffer from impaired memory, which because of due to the infection or maybe neurological complications will affect their memory. Besides that, they also feel anxiety, depressions, or feel irritable by someone. Maybe they have some of them which do not want for the treatment, and also violence. I think that's all.
Yes. Okay, any more?
I think if the pregnant woman if infected by the malaria, it will feel bad, because it will cause miscarriage of the baby. And I think this will cause depression in the patient too.
Okay.
And
yes.
also foreigners which bring the malaria and infect others people, they will feel guilty and feel bad for others.
Okay. Anything else?
I'm not really sure what point, but there was also a thing where there's an agreement between when there is malaria, there is also like poverty. So like poverty is linked with malaria. So in that case, like people really think like when people are poor, it's easier for them to get malaria in that case. Like especially in African countries.
Yeah. Okay. Any more?
I want to add some more. I found that the admitting diagnosis was Plasmodium falciparum, malaria complicated by acute renal failure. This feeling were accompanied by irritability, reduced appetite, insomnia, and reduced energy.
Yes. Okay, so there are several psychosocial implications of malaria. Okay. All right, so I suppose that's enough. Okay, can we move on to the next one?
Yes.
Yes, sir.
Prevention. Yeah.
Can I?
Yeah.
Yeah. The prevention method. The first one is we can avoid mosquito bites by wearing suitable clothes, such as wear long sleeve clothing and pants at night, and use insect repellent. Also use bed nets treated with permethrin. Yeah, and for travelers visiting endemic areas, chemoprophylaxis by taking drugs such as chloroquine or Fendizer before and after traveling. Also vaccine. Since October 2021, WHO also recommend malaria vaccine among children living in region with moderate to high Plasmodium falciparum malaria transmission. Right, the vaccine has been shown to significantly reduce malaria and deadly severe malaria among young children. And also control strategies. We can at the elimination of vector mosquito or vector control. For example, fogging or area spraying, indoor residual spraying or IRS, and source reduction, where removal or permanent destruction of mosquito breeding site. Other than that, we can distribute the treated bed nets. For example, insecticide treated bed nets. These are used for treating bed nets kill mosquitoes as well as other insects, and the insecticide also repel mosquitoes, and this will reduce the number of mosquitoes that enter the house and attempt to feed on people inside the house. Yeah, that's all.
Okay.
I'd like
Can
to
you-
add on
yeah.
what I said earlier. The type of drugs we use depends on the type of malaria is present in the area. For example, in much of Africa and India, malaria is resistant to chloroquine. So this cannot be used as a prophylactic. In parts of Thailand, the resistance to mefloquine has emerged. So however, if the appropriate type of prophylaxis is used, it is very effective against malaria. Thank you. Yeah, that's all from me.
Yeah. Okay. So again, I want to emphasize the point that for you to prescribe or give drugs for prophylaxis as well as for treatment, you have to know the pattern of resistance in where that person is traveling or where the person acquired the malaria from. So that's how you choose.
I would like to add on about case detection and investigation. For if some areas which there's a malaria case increasing of the case, um, a mass blood surveys will be conducted to see the source of infection. The case will follow up for monthly. For example, for Plasmodium falciparum and malaria, it will follow up for weekly for 28 days and 6 months, and monthly for the following 5 months, which is the totally 6 months. And for Vivex and mixed mixed infection, it will follow up for weekly for a month and the next following 11 months. So the follow up the cases is to prevent the to prevent the spread of the malaria infection to others. And also for there's for the prevention and control strategies in Malaysia, health education is to build up awareness among the citizen and the endemic region. That's all. Thank you.
Okay, good.
Can I add something very short on it?
Yeah.
For Atira's part, she mentioned something about putting insect repellents, right? So for the insect repellents, normal kind of insect repellents may not really work effectively for a long duration. So we should choose insect repellents that contains DEET, which is known as diethyl toluamide. So higher concentrations of DEET will give longer duration of protection. That's all. Thank you.
Yes. Okay. Okay. Anything else? Okay. If not, we move on to the next one. Okay. Anything to add on the campaign?
I think I'd like to add up on the campaigns. Let me share my screen. Can everyone see my screen? Okay, this is the campaign that has been brought up by WHO, World Health Organization. The Zero Malaria campaign starts with me. It engages all members of society, political leaders who control government policy decisions and budgets, private sector companies that will benefit from a malaria-free workforce, and communities affected by malaria. And also, I'd like to show up on the other one, Take a Minute to End Malaria. This is like a campaign which is an online and mobile effort to get more mosquito nets into hands of people who need them and save lives. So we can either donate online, or buy a book that can donate a net. And this one is from Sabah, if I'm not mistaken. Yeah, Kota Balut in Sabah. It is important for the community to take precautionary measures to prevent malaria infection in line with the theme of World Malaria Day. So if you look at this campaign is named as Sifar Malaria Bermula Dari Kita. and which is Zero Malaria Starts From Us. So these are the programs that the government and NGOs which provide. It will basically give a more effective impact in our efforts to educate people on this disease. Yeah, that's it. Thank you.
Okay, good. So anybody wants to add any more? So the various campaigns starting from the WHO. No more? No? Okay, okay. We move to the epidemiology. Who has got figures for Malaysia?
May I share my screen?
Yeah.
All right. All right. So this is what I have for my for the epidemiology. So this is the number of cases by Plasmodium species in Sabah and Sarawak. The blue one is Knowlesi. The red one here is Plasmodium vivax. The green one is Falciparum. The purple one is Malariae. And the oval is the orange one. Yeah. And this is for Peninsular Malaysia. Again, they are classified in colors as well. And this is for the whole of Malaysia. Right. Yeah, that's all I have to share.
Okay. So which is the predominant species in Malaysia? Norzai.
Norzai and Vivax.
Norzai and
Yeah.
Vivax. Okay. Norzai and Vivax. All right. Okay, so that's the epidemiology. Okay. Prevention. Sorry, the act. Okay, Prevention and Control of Infectious Disease Act. So, have you discovered what this act is all about? Have you got a copy?
Yeah.
Okay, where do you find your copy?
Just type it in Google and
Google
there's
and
PDF.
you found it. Yes. Yeah, so it's available on the internet. All right. So what did it say about doctors not reporting, and what are the consequences?
I will read. I found one that relate to the medical practitioner. It, at Part 4, Control of the Spread of Infectious Disease, Section 10, Requirement to Notify Infectious Diseases. Point number 2, every medical practitioner who treats or becomes aware of the existence of any infectious disease in any premise shall, will the least practicable delay, give notice of the existence of the infectious disease to the nearest medical officer of health in the form prescribed by regulation made under this act.
Okay.
That's one.
So we have to notify with the least amount of delay. Okay, anything else important in that act somebody found?
I will share about the act notification and tracking of the malaria. from the and then the cases should before this the cases should be notified within 7 days, but it's shortened to 24 hours in order to control the malaria disease after under the act, under the Prevention Act, and 3 days in Sabah Sarawak as it inadequate of communications service. That's all.
Okay. All right. So 24 within 24 hours if it's in Semenanjung, but you can extend it up to 3 days in Sabah Sarawak because of delay, problems with communication. Okay. All right. So I think never mind. You have to slowly learn the provision of that act, which will affect your practice later. But because you are not really practicing at the moment, so not to worry. Okay. We have time. Okay. So the last learning need, what is the role of the public health department?
Can I?
Yeah.
Right. Role of public health department, they will interview the patient and conduct screening test. That's what I have.
Yes. Mm-hmm.
I'd like to add
Anybody wants to elaborate? Yep.
So public health professionals, they try to prevent problems from happening or reoccurring through implementing educational programs. And then they also recommend some policies and administer some services and conduct research. In contrast to clinical professionals like doctors and nurses, which their main focus normally for doctors and nurses are to treat the individuals after they become sick or injured. Public health, they also work to limit health disparities. A large part of public health is also to promote health equity, quality, and accessibility. That's all from me. Thank you.
Okay, so that is in their function in general lah. In general, okay. Anything specific to malaria? Actually, just apply it to malaria. Okay. Yeah, I mean, in terms of malaria, okay, they deal with the prevention aspects, educational programs for malaria control. Okay. Yeah, I mean, we just apply it to malaria. So different from the clinician. Okay, clinician will manage the cases in the ward, but this public health people will be more dealing with policies of prevention, eradication, okay, services, and so on. Okay, anybody want to add any more before we finish off?
Public health professionals, they are still doctors, right?
Yeah, I mean, there are various categories. Okay, they are public health doctors. There are also public health officers who are not doctors. Okay, so there are various categories.
So the doctors who are in public health, they actually can still diagnose, right? And they can still practice, right?
Yes, yes, yes. Mm-hmm.
Okay, thank
Yes.
you.
Okay, have we finished? Anybody else has anything else before we sum up everything?
One thing, I just want everyone's opinion on this lah. If we see Justine's, what do you call that? Demographics, the one that he showed, all the graphs and stuff. We noticed that Semenanjung Malaysia and Sabah and Sarawak, they all have Plasmodium knowlesi. They both have zoonotic malaria. So why do you guys think that the in the trigger, the Semenanjung person, the Semenanjung doctor, did not really recognize it. What do you guys think?
From what I know, right, for Semenanjung, the cases for malaria, especially for Plasmodium knowlesi, they usually occur in Kelantan, more specifically Gua Musang. And this might be a far-fetched idea, but I think the guy from the Semenanjung, he works in Johor Bahru or somewhere, so he doesn't really know.
Correct. Because in Semenanjung, is the areas where it is very limited. Okay, what Carol said is correct. Okay, certain areas of Pahang as well. Okay, so it's not widespread as in Sabah, Sarawak. Okay, so if that person has been working in Kelantan, he should know. So maybe, yeah, okay. So since Annabelle brought this point, so maybe I should feed it back to the one who created this trigger. Maybe not to correct, just to generalize it to Semenanjung, maybe KL or something like that. Maybe that's okay. Yeah. All right. So yes, good point. We need to improve the trigger. Yes. Now because people are aware of Nolzai. See, before that they thought everything was malaria. Because the morphological similarity, it was diagnosed. So now everything which is Nolzai, I mean, which appears like that will be diagnosed as Nolzai. All right. So that's why you see the rate is increasing. All right. Anything else? No. Okay. So if not, can I get now? I need somebody to summarize rather than me. Who wants to volunteer to summarize? What we have learned this week. Anybody? Cool. You want to try?
Okay, I'll try. Okay, basically about this trigger, we highlight first thing we highlight about the life cycle either in the human host and also the life cycle in the Anopheles mosquito, female Anopheles mosquito, and then we get into the prepatent period and incubation period for each plasmodium. Okay, which just now I think Yen summarized give the average days for each of the plasmodium, and then we also compare and see the morphology for each of the plasmodium, either in ring, either they are in ring or because of different stages at trophozoite, cytozoites, and also the gametocyte stages. And then we proceed into the type of anti-malaria drugs and the mechanisms which is more effective against general treatment, and some will like not really active in either liver stage, or some of the drugs is not suitable for the pregnant women. Also, some drug classes which is only targets certain plasmodium. So we get the idea of these anti-malaria drugs, and we also know the habitats where we can usually found the Anopheles mosquito and their breeding site and their lifespan, incubation period, their biting habits either between sunset and sunrise. And we also know that the reservoir host is the macaque monkey. Usually we can find, I think Sabah Sarawak there is more of this monkey. And the signs and symptoms, we know the signs and symptoms after the person having this kind of infection. And the laboratory investigation, and we usually will use the blood film more compared to the others, PCR, which is not really widely used because of the quite expensive. Then complications if we someone get malaria, the complications, okay, and the risk factors. The psychosocial implication we usually know they will have reduced energy, this kind, etc. A lot of psychosocial implications. And under the population, we know the prevention. We know have to, for a person we've come from the known malaria countries come to malaria. We have malaria cases like Malaysia. We know that we have the person have to take chemo prophylaxis. Okay, and for the campaign, we know that we have sorry, zero malaria start with me, and so the epidemiology just now show that the majority of the cases are caused by the Plasmodium knowlesi, and also another one I think is sorry, I forgot another one, knowlesi, and another one is
Vivax.
Vivax. Thank you. So also the last one is the role of public health. Okay, they usually interview, conduct screening, and also test, implement policies like what Annabelle said, educating the publics. Also, yeah, I think that's all for this is a summary. I think it's quite long for a summary. Yeah, thank you.
Okay. All right. Okay. So let's have a quick feedback. Let's start with Annabelle.
Hi everyone. So for this time around, I think all is well lah. I feel more comfortable with this group, to be honest. Like for this week, especially, I guess since as we go along, like we get more used to each other lah with time. So today is nice. This session is nice, and the previous session was nice also. So thank you Atira and thank you Ku for being this chairperson and scriber. I look forward to our next PBL really, and I enjoy learning with you all. Yeah, that's all.
Okay, Justin.
Just like what Annabelle said, so like, yeah, we're getting along better. So like, I feel comfortable as well. But like before starting the PBL, I was still nervous. But then like, as we go along to doing the PBL, I feel much more comfortable with you guys. So thank you. And thank you to Atia and Ku for being the chairperson and the scribers with me. I also look forward for the next PBL. So yeah, see you.
Okay, Carol.
Compared to the first PBL that we had, I think we come a long way since then. Everyone seems to be working well, so I guess that's great. And also thank you to the chairperson and scriber this week, and I'm looking forward to learning with you guys more after this. So that's all.
Okay, cool.
Okay, I think learning during PBL is much more fun than but watching videos of the lectures given, because this will allow me to fast how to say that I can learn something which more I can remember the things more easily because of they give certain points that I can remember rather than reading the notes, everything compared. So I think PBL is quite fun. Yeah, that's all.
Okay. Lynn.
And I think because malaria is quite complicated, as there's a lot of Plasmodium species and the life cycles, a lot of stages, and also the mosquitoes is also complicated, the life cycles. So I think through PBL I can learn a lot, and it make me easier to understand a lot of information. And also I'm glad that the other members can find a lot of information that I can't manage to find it on myself. And so I think this session is very good, and I learned a lot from them. Thank you.
Okay, Nani.
Hello everyone. Just like what everyone said earlier, compared to our first PBL, I feel this one we are more comfortable with one another and we are very open to receive any type of information given by everyone. Just like what Yenin said, everyone have different opinion and some information I couldn't even find by myself. But thanks to you guys, because of you all, we get to understand things better. Just like what Koo said earlier as well. Yeah, based on lecture notes, it's hard for us to understand when it comes to life cycle, about the merozoites and everything. It was very confusing for me to understand by my own. But thanks to all of you guys, we get to understand based on our preference. And yeah, I feel we've been through a really long way. We've gone through a really long way. And thank you so much, everyone. And thank you to our scriber and the chairperson. And I hope to learn more with you guys. Thank you.
All right, Atila.
Alright, hello everyone. Okay, I think this session I think we improve and it is nice to learn with you guys. And then sorry for not being a good chairperson because okay, here I want to thank Professor because I think Professor lead us more and then yeah, I learned a lot from you guys because I think we use the same platform to search for the information, but I cannot find many things that I cannot find. So I found that PBL session is very beneficial so that I can learn more from you guys, different perspective, different ideas and informations. Yeah, I think everything is good lah. Yeah, that's all.
All right, Kasara.
Just like all you guys said, overall I think this PBL is a bit complicated for me to even understand. So all of you guys punya explanation is clear and easy to understand. And yeah, I look forward to the next PBL.
Okay, Shafinas.
Okay, hello everyone. Okay, honestly, I really enjoy this session because maybe we get along. I'm sure that future PBL we get along more. And then I also very grateful for from Professor and my friends because the information that I can get from Professor and my friends. Yes, sure. As Koo and Nani said, that is hard for me to learn by myself. So I think with PBL session, I will gain more knowledge, I think. That's all from me.
Okay, maybe just one message from me. Okay, if you feel that I'm too dominate your session too much, I think try to say so.
No,
So that,
not at all. We actually enjoy it.
Not at all.
Yeah, I
Because
think
of
without
you, get to understand things a lot more better. Actually.
I mean, there are certain points which I want to emphasize, but in terms of controlling, can we move on? Can we move on? So if you feel that you this one I'm too domineering in that sort of thing, please let me know. Okay, so I let you have more say. Okay, so I think we stop here. Okay, so I'll see you next maybe after Christmas. Okay, so have a good time, all of you. Enjoy your session. Okay, I think the practical will be enjoyable. Okay, so enjoy your session. See you all.
Alright.
Okay,
Thank you so
right.
much.
Yeah.
Thank you so much, Professor.
Thank you
Thank
so
you.
much,
Everyone.
Professor.
Thank you
Thank
for
you.
all.
Thank you.
Thank you. Thank you.
Bye-bye, guys.
Bye-bye.
Bye.